Jay Hall. I'm an audiologist.
I'm Bob Margolis. I'm an audiologist. So Jay, what's your experience with AMTAS and how did you become aware of it?
I knew that your efforts were underway at the University of Minnesota, and I knew there were other. I actually was aware of other automated systems that were being developed in other parts of the world. So I kind of had that on my radar, and I said, well, I'll just kind of monitor this to see how it's going. I don't know if you remember, 9 to 10 years ago, we were both asked to speak at a state meeting. So I was sitting in the back of the room, and I said, you know, I haven't heard Bob Margolis give a presentation since probably some ASHA convention way back when. I'll just sit here. Literally, that was the first logical, systematic presentation I had heard. I was also quite surprised when people started asking some thorny questions, and it was almost as if you'd struck a nerve. And I think I was as naive as you in thinking people would say, thank you for handing us this holy grail instead of, attacking the messenger. And my mind was moving ahead already. I said, this is phenomenal. And I started thinking of the problems it could solve for us, we audiologists. And because I have a really international perspective, I was thinking as much about how it could reach people with no hope of reaching accessing an audiologist in other countries.
There are 11,000 audiologists, full-time equivalents, and about 6,000 hearing aid dispensers. Mm-hmm. And if you figure they're working every day, the number of audiograms they could produce is about 17 million in a year. The number of who needed them was in 2020 was 35 million, just over double the capacity. That gap is going to increase because the number of audiologists and the number of hearing instrument dispensers is not growing. And so in 2060, the projection is that there will be a need for 47 million audiograms, and the capacity is still 17 million. Mm-hmm. That's such an enormous gap.
Seems hopeless.
It's hopeless with our current delivery model. If you want to get a hearing test, you pretty much have to go to an audiologist, to a clinic. Mm-hmm. We have to make hearing testing available in other places. How about your home? Mm-hmm. You should be able to do a hearing test at home.
Sure.
You should be able to
go to the mall, or
primary care physicians
absolutely.
Should be doing basic hearing testing as part of their physical examination. They call it the introduction to Medicare examination, says that they're supposed to get a hearing test. Well, they don't. They get that's what they get, right? Right. There should be hearing testing available in a lot of different venues other than an audiologist's office. That's the only way we're going to make a dent in this.
One population, there are really two populations that immediately came to mind as you were talking. One is the public schools. That would be a perfect place for automated. Right. And the other is skilled nursing facilities or nursing homes, because the research shows that the vast majority of people in a skilled nursing facility have hearing loss. In fact, that's often misinterpreted as cognitive decline or dementia, and many can't really easily leave to go to see an audiologist.
And they're not getting tested?
Not at all, no. They're being ignored. It's a shame. And some of them, perhaps, if they were properly managed, wouldn't even need to be in the skilled nursing facility. They could get back with their families. And from just a pure economic point of view, wouldn't that save the government and Medicare and society a lot of money? But right now, as you say, they're virtually not served at all.
And they do fine with automated audiometry. Mm-hmm. They do just fine. We've tested patients in those settings.
Well, and the quality measures, our indicators, would be perfect there, right? Because then, like you say, if it showed that the results were unreliable, that person, it'd be a minority, would then be evaluated by an audiologist.
Jay, what's your experience with reimbursement for automated audiometry?
Good question. It varies from state to state. Obviously, internationally, there would be other issues. It's a problem. I think it's a problem, and it's because the third-party payers are kind of expecting the traditional model. And there were some changes, actually, in rules and regulations and policies during the height of COVID. There was more receptiveness to telehealth delivery and automation, anything that would allow you to safely provide services to patients. But that has to be addressed, and the data need to be presented in a context of this is a good thing. We're not trying to cheat somebody or cut corners. We're actually trying to extend services to more people in a more cost-effective way. Honestly, in most places, there would probably be some questioning about actually submitting an audiologist bill for providing a CPT code where they expected the audiologist to actually turn the knobs and press the buttons, and yet they found that an automated device was being used.
When the CPT codes were developed, automated audiometry didn't exist.
And those are hard to change, but they can be changed. As you know, there are audiologists represented on the panels that do that. So that should be a top priority, absolutely. Yeah, that triggers two thoughts. One is that the average audiologist who performs what's called a comprehensive audiologic assessment does not get adequately reimbursed for their time and their effort and their expertise. I mean, it's really a crime that they get reimbursed. But we're not going to change the fee structure. Automated audiometry allows them not to spend that time, which is not a good use of their time, and instead they can focus on where their skills are needed and where more revenue can be generated. So you would think that would be at least attractive to audiologists.
And I think it is more and more. I think they see that. I analyzed how my staff was spending their time. They spend more time doing pure tone audiometry than anything else we do.
And we're both involved in the education of students. I think we really need to put a lot of effort into making sure that every graduate of an AUD program in the United States views automated audiometry as an essential component of their clinic. In other words, they wouldn't even think of operating a clinic without it, because they're a blank slate. They don't have any preconceived ideas. Many of them probably want to be as efficient as possible right from the beginning in their career. I think that the future of audiology for the students would be much brighter if they could look at this new model that we've been describing.
And I think they are coming around to that point of view.
Yeah.
I think they are seeing the rationale and the need for it and how it will help them in their practice.
AMTAS is established. You've obviously done the validation. It's now out there being used. Anything new coming along that you'd want to tell me about?
It's continuously changing, improving, as we find new ways to make it better. One thing we changed recently was in how we approach bone conduction testing. When we're testing manually, we know that if you have a symmetrical sensorineural hearing loss, you can test unmasked bone in one ear and have everything you need. So our approach initially was we were testing masked bone in both ears. So to make it more efficient, save some time, and provide still the same quality of information, we now test unmasked bone first. And in a majority of patients, that's all you need.
Beyond pure tone audiometry, automation sometimes is even easier, certainly for otoacoustic emissions. Of course, tympanometry can start the moment the probe is securely placed in the ear, and then immediately acoustic reflexes can be measured, and that can also be automated. In my opinion, you really haven't evaluated somebody's hearing until you've evaluated their speech, their ability to perceive speech. What are the options for pulling that into the automated realm, so that let's say you're in Mexico or I'm in South Africa, where the patient can basically get from otoscopy right through the test battery, can be evaluated much like an experienced audiologist would evaluate them if there were an experienced audiologist. So how do you fit the speech audiometry component into it?
So if you're doing our conventional tests, which is presenting words in the language of the patient, that can easily be automated. The way we do it, by presenting a word and having the patient repeat the word, and then the audiologist tries to decide if they said it correctly or not, that can be automated. So we've developed a procedure that uses a touch screen for the patient touches the word they think they heard.
So it might be like 4 words that are different, deviate in one phoneme, are different in one phoneme.
We present a word, and then we have 4 alternatives, and we use rhyming alternatives to make it a little more difficult task. So if
In
the
a
word
closed
is
set?
in a closed set,
Yep. Okay.
so the patient hears cat, and they see bat, rat, fat, pat. Well, one of them has to be cat.
Right.
And they touch the word they think they heard. So we've developed that, validated it, collected norms on it.
And it's for both speech reception threshold, recognition threshold, as well as word recognition.
Exactly. So the problem, though, is that there are 6,000 languages on the planet. And to develop word recognition materials, that's a little daunting. And so we're working on a procedure to use non-linguistic speech stimuli, which sounds like a oxymoron, but we use stimuli that have the characteristics of speech, but are not speech, are not words. And we've developed a procedure where the patient listens to those and then discriminates between 2 similar stimuli. And we think that tests the same thing that our word recognition tests test, which is the ability of the cochlea and auditory nerve to encode the correct speech stimulus.
Going back to the basics of psychoacoustics.
We are in audiology, we're most concerned with sensory neural hearing loss. Well, that's a peripheral, that's a cochlea issue. There are no words in the cochlea, only pressure waves. If we can evaluate the ability of the cochlear and auditory nerve to encode a speech stimulus, then we're getting at the same thing that our word recognition tests measure for patients with hearing loss. We've done preliminary studies on that, we've standardized it, and now it's just about ready for that to move forward.
So that type of test would not be inadvertently evaluating a person's linguistic abilities, which you don't want to do. It would isolate their auditory abilities. So theoretically, it could be a universal, worldwide test that was almost, you might say, standardized on billions of people.
The language of the listener becomes irrelevant. And we think, and because the auditory system is the same everywhere on the globe, we think we're measuring the same characteristic or the same processing mechanism that we measure with speech recognition testing. So that's a way to, again, to increase access to this basic test. This isn't really part of AMTAS, but working with Grason-Stadler, we've developed a noise monitoring system and rules for interpreting background noise and when it can potentially interfere with the test.
And there's a message that whoever is overseeing this test will be able to read.
One thing that there is an ANSI standard on maximum permissible ambient noise level for hearing testing.
At different frequencies.
Right. That was written for the old TDH style supraoral earphones. And so we adapted those. When you use the circumoral earphones that we now use, they have very good noise exclusion. So you can tolerate more noise in the environment than we could with the old earphones. So this has been a feeling of mine for a long time that when you have noise in the environment, the distracting effect of the noise to the patient is just as or more disruptive or influential on the hearing test than just the masking of the
Sure.
of the test tone. Distractions, I think, really affect the quality.
Well, you know, as a clinician, I know there are some patients where you have to keep telling them, no, don't pay attention to that masking noise. Focus on those little beeping tones.
And so we developed, and we did an experiment in which we had people do just basic pure tone AMTAS audiogram in the presence of a distracting noise. And the effect of distracting noise on the thresholds is different from the effect of masking.
It's more of a central, obviously a central effect
Yeah.
than a peripheral.
Yeah.
Right.
We were able to determine at what level noise in the environment becomes distracting to the extent that it affects the audiogram. And so now we have another kind of alert, what we call a distraction alert. More and more now we want to be able to test in environments outside of a sound room, and it may be doors slamming, telephones ringing. We monitor that with the hardware that Grason-Stadler has developed with a body-worn microphone to monitor the ambient noise. And then we have a rule for at what point the distracting noise could have affected the audiogram.
So Bob, what's the biggest change throughout your career in audiology, your long career? What's the biggest change in audiology that you've experienced?
That's easy for me. It's the AUD. I think the conversion of our field from a master's degree field to a doctoral field was critical. Not just because it enhances the resume of the clinician, but because it provides a higher level of education. And you know, many of us who were advocating for the AUD predicted that we would attract better students into the field if we offered a higher level product. And I think that has happened. The directors of several training programs have told me that the average GRE scores of their applicants went up significantly when we changed over to an AUD. So it was an appropriate way to progress to a real healthcare giving field that is equivalent to the other fields. It also allowed the PhD to revert back to what it was supposed to be, which is a research and teaching degree.
That's so important. And every now and then, just recently, I was asked, well, didn't the AUD reduce the number of PhDs? And I said, well, there's a PhD shortage in many professions, but not really at all. I think that you had people now going on for a clinical degree who really should be. They weren't people who were going on for the PhD who really wanted to work in the clinic. Like you and I, we had no alternative. The biggest change I've seen is actually very closely tied to the AUD, that's part of it, but it's the changes in technology. And audiology has expanded and improved with general technology, obviously from the transistor and hearing aids in earlier years to computer technology and digital signal processing. I remember one time Jim Jerger, when I was in Houston at Baylor College of Medicine, and I naively said, Dr. Jerger, I wish I was in your generation, because then I would have experienced all the most exciting developments that are ever going to occur in audiology, because I couldn't envision that things would advance from where they were. And he just laughed and said, oh, you'll see plenty of changes. And sure enough, soon after that, OAEs came on the scene, and cochlear implants, of course, they were unthought of, at that point. They're available, all kinds of options for amplification for fitting just about everybody, and then diagnostic tools, and of course now we have automated audiometry. So I can't really say there's been one single change that's been
And
remarkable.
that's a change that is ongoing, and
Yeah, it's constantly
the
changing.
The progress in the technology has really been remarkable.